welcome to the next iteration of the AAST Grand Round Series. For those of you tuning in, I think you're in for an annual treat. The PEDS Committee and Dr. Notrica each year puts together pediatric-centric case presentations and panels, and we lovingly call it the Experts in the Hot Seat panel. And for those of you who haven't witnessed this before, let me assure you, we have a good time with this. This is fun for us, and so thanks for joining in and hopefully being entertained as well as educated. So as mentioned, Dr. Notrica, David Notrica, is going to be our moderator. He comes to us from Phoenix Children's, and I think David, now you've been demoted down to the chief of staff. You're no longer trauma director, I think.
I'm still the trauma medical director.
Oh, good.
And the program director, and
I understand how it works.
Yeah.
Katie Russell, coming to us from Primary Children's in Utah. Mary Edwards from Albany. Romeo Ignacio from Radiant San Diego, and Howard Pryor from Texas Children's in Houston. I will also acknowledge, and I'm not going to name them out, but just by chance, there's an amazing military history presence in this pen, and I'll let everybody decide who was active duty in the past and who wasn't. You'll figure it out. All right, Dr. Notrica, take it away, and I'm going to go off camera.
Okay. Hey, so I'll be moderating. The way it's going to work is that each of our panelists is going to present a case. The other panelists have not seen this case, and so they'll ask our panelists, put them in the hot seat. I love the title of this because it implies that we're experts, which I love, because I think most of us are just kind of working stiffs who do this and love doing it. And then the hot seat is really true because I get to put every one of the other panelists in the hot seat, ask them questions and make them answer. All right. So with no further ado, Dr. Katie Russell.
Hi, everybody. Thank you so much for having me. I'm going to tell you about a case that we had a couple years ago at Primary Children's Hospital. So here's the scene of the accident. We've got a lot of ATVs where we are, and this is pretty frequent for us. So this kid showed up about 1:30 in the afternoon, and it started as a trauma 2 activation. So we've got a 10-year-old female who was in some kind of an ATV rollover, and they're coming air med from the scene. The kid got there, and the kid was actually breathing. Her airway was intact, seemed to be breathing relatively unlabored, was on 2 liters, but was only satting 91%. She had pulses. Her heart rate was 129. She was GCS of 15. Her pupils were equal, and she was moving all 4 extremities. Here's her chest x-ray. So what should we do? Open it up, Notrica, or just keep moving?
Let's just, for the sake of practice, let's toss this one to Howard. Howard, looking at that X-ray, what are you going to do with that?
Place the chest tube fast as reasonably possible at the bedside.
Let's do it, Howard. So we got it in, and this is what it looks like. Well,
all right. The 3rd year did it, apparently. But that looks like you're not getting all, and it's bubbling briskly, I imagine.
The 3rd year did not do it, and it is bubbling briskly.
Okay. So it's
real briskly.
So this is suggesting that she's got a pretty significant, more central type lung injury, which is kind of unusual for her mechanism, but I would consider putting a second chest tube in at some point, but if she's stable, we have time to collect ourselves, I would try to get other information before doing any further investigation. Sounds like, what's her SATs now, by the way?
Yeah.
Her SATs now, they're like 85. She does still look reasonably good. Like, actually is talking, is making sense. Her SATs are down to 85. Air Med said they showed up on scene and the ATV had literally crushed her. She was under the ATV, but they were able to get her out. And we agreed with you. We with the SATs going down and with the look of that chest x-ray, we did upgrade it. So we upgraded it to a trauma 1, this just gets us at our hospital a few more resources. So we
Yeah.
get an anesthesiologist, we get another PICU nurse and a PICU tech. So we upgraded it about 5 minutes after the kid got there. And this is our anesthesiologist. It's somewhat of a you know, a little bit of in jest, but one of the best doctors in our hospital was actually there and came down to help us. And we got that second chest tube in, and this is what it looks like.
Yeah, so Katie, I like that phrase when people say, "Oh, they look great" or they look stable until they don't, right? That's the
Yeah.
thing with kids and stuff. And so after that second chest tube, just like Howard said, how's the patient doing?
You know, the stats are now 78.
So, Mary, what's your take on this X-ray?
I mean, it looks worse. I don't know. Maybe I didn't look at the other one carefully enough. but
Yeah,
I think I start to
no,
see,
I agree. It looks worse. Why does it look worse?
well, you're seeing mediastinal shift, and I think I see maybe I'm just seeing a big dilated, I don't know, air coming over in the anterior mediastinum, but it almost looks like there might be some pneumomediastinum. It's hard to see, but this looks scary to me, honestly. I
Looks like
think
a-
we need to go to a different type of room with this kid.
This looks like a central, this looks like a
Yeah.
central airway avulsion.
Yeah,
Yeah.
you have no aeration of that lung, almost like the lung is not only, not flattened, but it's just basically centralized, despite having 2 chest tubes on suction, and now they're bubbling quite a bit. And so just like, Howard said, this is a central injury to the airways.
Yeah, I would say this is virtually pathognomonic. So we got badness here.
Yeah.
Sometimes I have an X-ray similar to this, and sometimes I'll ask the residents, all right, should we put in a third chest tube?
And those are real chest tubes. Like, that's not the pigtail messing around stuff. That's like hardcore. I like Mary's idea. We're in the wrong room at this point with this kid.
Right.
Yeah,
This
so we're thinking that too. We're thinking the exact same thing. But the kid is now, straight, the stats are down to the 50s and the kid no longer looks good. So we now make an attempt at a left main stem using a bronchoscope, and we have the anesthesiologist. But I can tell you it wouldn't go, like we attempted that and we couldn't get it for, however the mechanics of this are at this point in the case, couldn't get it to go. And at this point, we're really only about 10 minutes into this trauma activation. And at this point, 2 years ago, we had an additional page called an op upgrade. So we upgraded. We didn't think we could transport to the OR, but we did get some more staff down there. And while this is kind of all going on, the kid codes.
Yeah.
So we're now in the trauma bay. We have a lot of resources. We only have 1 surgeon in the hospital at any one point, no residents, no fellows. But, we have people in the trauma bay and the kid code. So the kid got CPR only for a couple of minutes. We ended up giving a couple rounds of epi, and this, I think about this all the time. We did a right-sided resuscitative thoracotomy. And my friend, Dr. Kastenberg, that was actually part of this case, he always jokes about how he was going back and forth in his head about, am I sure I want to go on the right when I'm doing an ED thoracotomy? But, in this case, it was clearly the correct.
Can I ask a question?
Yeah, go for it.
It wasn't an anterolateral, was it? Did you roll the kid up?
It was a thoracotomy. It was like
It was posterolateral?
a quick thoracotomy. So anterior, posterior, whole thoracotomy. And, you could see on that thoracotomy, you could actually see the bronchial injury in the trauma bay. And so we had a, this was in July. So we had like a day 6 intern now with his finger on this major bronchial injury. Still attempting to get that kid main stemmed. But, there's just air leaking out of this thing despite our best efforts. So what would you guys do at this point in time? We're still downstairs in the trauma bay.
Hey, let me take you back, Katie. Let me call you out on this real quick. So go back to the previous X-ray. Okay.
Here we go.
How long between the time you put the second chest tube in and the time the kid arrested?
Not much time, like pretty
Yeah.
much immediately. It was like, it's one of those cases where you could see the stats, come in at 91,
Mhm.
second chest tube goes in, you're in the 80s, now you're in the 70s, and now you're coding all like within the first 10 minutes of the kid's arrival.
So would anybody have done anything else as the kids crumping?
Sometimes
Go ahead.
as you sit there and you talk about this, it seems like the chest tubes made things worse, And so I wonder, as the chest tubes go in, if they don't sort of push on the lung parenchyma and kind of open it up some more or something. I don't know. So hindsight's 2020, but maybe have gone to the operating room after the first tube when you just knew what you had to deal with.
Yeah, I agree with Mary because, once it goes the path of least resistance, right? So you had one chest tube and now you have an air leak. Now you're trying to ventilate. Now you have two chest tubes. It's gonna make it worse altogether. I think that in your mind, after the first chest tube, you were already thinking about it. And at that point here, before I even, the anesthesiologist is getting ready to do that main stem, I'd be prepared to do a thoracotomy, or like Mary said, if I had time, go to the OR in a more controlled setting. So, but
Well-
you probably didn't have that much time in this particular case. So
And Dave, were you thinking after the first chest tube and you didn't get this and you had this terrible air leak on suction to try water sealing? To see if-
I had a case almost identical to this, and we clamped one of the chest tubes, and that bought us enough time to actually take the kid to the OR, and so I think Romeo just nailed it, which is that it's a path of least resistance, and you actually need a little bit of back pressure, tension or no tension, in order to ventilate the left side. And so what you lost was the ability to ventilate the left side. So if you had looked at, given, I'm sure everybody's, and this is armchair quarterback, and I wasn't there, but I would bet you that when you put the second chest tube in, that the left lung stopped ventilating. That's what I would bet.
Yep.
So, all right. But now we've got a kid with their right chest open and the intern's finger in the dike.
Right.
Okay. Don't you love it when everybody plays, Monday morning quarterback 2 years later?
And we've got no pulse.
yeah, that's the problem, is now you've coded. But
Yeah.
probably what to Howard's point was, after that first chest tube, it's always hindsight, right? 2020, but obviously after first chest tube and it's leaking that bad, you were already thinking about it. And I have to tell you, I've seen a couple of similar cases where they put the second chest tube and then the patient goes even quicker, decompensates and codes and stuff. So
yeah, and
now,
clamping it is safe because I've done it.
The best part about clamping it is you can unclamp it if you think you have that tension. You are controlling it. You're controlling the back pressure, controlling the physiology. It's just that comfort zone of realizing that up front. But that X-ray, for the audience, that's a classic X-ray that you can learn a lot from that. So
yeah.
And
now,
I think too, it's so good to talk about these cases because we will see this one again, right? Someone on this panel, for sure, someone on this webinar, like this kid's going to walk through the door. So I think this is such a helpful discussion.
Yeah, and I think and I like what Romeo's pointing out is when you're still on negative pressure ventilation and you water seal or clamp, like Dave's was pointing out, that's your moment. Once you go on positive pressure ventilation, which I'm not saying was the wrong thing to do either to defend the airway in general, but once you go on positive pressure ventilation, then you're really on the clock in a much tighter situation. That the needle hole just got infinitesimally small once you get on positive pressure ventilation. But it's tricky because those would be routinely the right moves.
Right.
This is not the usual injury.
And this is real tough for EMS, right? Because EMS intubates this kid in the field, like they really don't have a shot at this kid.
Yeah, that's right.
Katie, so now that leak that you see, where exactly the leak? Is it a complete disruption? Are the rings intact? How big of a defect are we talking about here?
It's big. I'm going to show you in a couple slides here, but it's like bronchial injury big.
Totally transected off?
Yeah, totally. Not the posterior wall still there, but there's a big injury and there's an intern's finger on it and we still have no pulse. So what are we going to do?
Well, Romeo,
Yeah,
you
so
go first.
So if that defect is somewhere where you can just put a hole in order to stop the leak and control the kid's physiology, that's the first thing I would do. You're still resuscitating this patient. You're still obviously now in a situation where you might have to do some cardiac massage. You're doing a massive transfusion protocol in order to. But the issue here is not so much you might have lost some volume, but the issue is you've lost the ability to ventilate this kid, and you have to bring this kid back. And so if you can put your finger, great. Now the preferentially goes to the left side, give some volume to that kid, see if that lung is expanding and stuff. Your right lung is gone because that's already, and I'm sure any type of craziness of trying to put a tube through the chest to the left lung, I wouldn't. I think you just need to control the leak and try to get some ventilation, oxygenation to this kid. So,
Dr. Edwards?
So the one time I had one of these, my N of 1, I guess, I was actually able to kind of take the lung and sort of rotate it up and kind of push it together, if that makes sense.
Oh, like a liver.
Exactly, kind of, only instead of like a big vein, it's just a bronchus. And so just by kind of, I guess you might have to take down the, the
Inferior
pulmonary ligament, but you could do that and you could kind of just push the lung up. If it was a main stem bronchus, I guess, from what you said. Yeah, and just kind of give a little bit of pressure there. And that might be enough to sort of stop it from leaking, because you just have to stop it and have someone's hand stand in the chest and while you take them back to surgery. I guess the only other thing I'm thinking is, you haven't ruled out any other injuries yet. I mean, is there something else going on? I guess you didn't see any blood on the other side with your initial chest X-ray, so that's reassuring. You can see the heart okay through the right chest, but it might be worthwhile to see if there's anything in the pericardium. And then is someone doing a fast while you're doing all this stuff? Just to look down there, make sure that we're not missing anything. Those are my only thoughts. And then of course, cardiac massage and the regular ATLS stuff.
hey Katie, I like this case because I just had one in an infant, and I was asking you how much of a disruption was because the other kid I was able to bring the edges of the wall, and that was enough just to get some ventilation to the right lung. So
yeah, so we pushed the lung up, we tried to close that hole. It was a long kind of linear tear.
Yeah.
Like we are still, we've still got our best anesthesiologist in the state of Utah trying to left main stem that, and the two will not go. So we're trying all these things and nothing's working, and we still don't have a pulse.
So two things. When you say that you don't have a pulse, you're not doing a very effective cardiac massage from the right side of the chest in my general expectation. So I would be thinking about clamshelling this kid the rest of the way over, cross clamping the aorta, doing cardiac massage so that you isolate the cerebral and the coronary circulation so your epinephrine will work more effectively and get the heart back. And that's in the hopes that there's nothing. Mary's right. If we don't fast the kid, I have no idea whether you're actually also bleeding to death in the abdomen is a separate issue. Then the only other thing I would think about, but again, this is not having the opportunity to see what you guys are seeing exactly. The other thing I would consider is from the chest side, putting a Foley into the bronchus and inflating the balloon and clamping the Foley hole itself to try to shut off that part of the circulation if nothing else is getting it done. That might not be worth the time depending on your situation also.
A Foley or a Fogarty?
I mean, if I had a Fogarty, I would prefer that. I would use anything with a balloon on it that I could get in there that could be occlusive quickly.
yeah, it's gonna be hard to do in a linear tear, right?
Yeah, it won't be easy. It wouldn't be easy. It'd have to be if something you could pull off. Just something I would think about as a
That's a good idea. Yeah, that's a good idea that I haven't thought of. So with compression and really with the intern's finger in the bronchus, we get a pulse. So we get a pulse, but it's like we are not in a sustainable situation. So we went on ECMO.
Oh, wow.
Okay.
Wow. I don't think any of us came with that one.
I like that.
Yeah. So we've done it before, like, so, because I'll show the data, but we've had a few cases like this over the last 10 years. And so we went on VA ECMO in this 10-year-old in the neck. We didn't think we'd be able to get an Avalon in VV, and it was also so tenuous, the situation, that we went on VA ECMO, which I love this x-ray. So if you see this, if you look at this thing, here's the intern's hand in the right mainstem bronchus. You know, here's your ECMO cannula. So this is your venous ECMO cannula. Here's your arterial ECMO cannula. Here's this that we could never get to go left. And then here's, you know, your thoracotomy, and then the clamps on the neck. So we got the kid on ECMO safely, and then we moved to the OR. And I think I've gone over my time a little bit. So we're before 3 hours. All that took kind of, it took a while. But about 2 hours we're in the operating room, and here's the hole. So it was just this huge linear tear that basically avulsed the right upper lobe, and then it was this big tear in the mainstem bronchus down to bronchus intermedius. So, and here you can see, I mean, look at this thing, you know, so it was really, really hard to control. But what we were able to do is the right upper lobe bronchus didn't look like it was going to be salvaged. So we did a right upper lobectomy and then a bronchoplasty, the main bronchus to bronchus intermedius. So here's where the injury was, just so you can kind of get a visual on that. But the right upper lobe went in the bucket, but we were able to save everything else and sew it back together. Here's some more operative pictures. And then here's what we look like post-op. So in the OR, we did left main stem the kid to just give this a little bit of protection for a couple days. We stayed on ECMO and put a couple of chest tubes in and a chest tube over there on the left. On post-trauma day number 2, we did a bronch and it this is the right main stem there. So these sutures are on that right upper lobe. So it looked pretty good. And we pulled the ECMO cannulas and then also pulled the ET tube back on post-trauma day number 2. Then on day 4, you can see this is the carina. So it looks pretty good on day 4. And the kid was extubated. So the kid was on single lung ventilation for 2 days, decannulated on post-trauma day 2, extubated on post-trauma day 4, 10 days in the ICU, and then went home 12 days after the injury. So I think overall the kid's totally normal, like no consequence from all this. So overall it was a great case that I do think will pop up again. So great discussion. Anything else you guys can think of?
How'd you manage the anticoagulation on the ECMO?
We anticoagulated the kid. So we scanned the kid after surgery. There was no other injuries. And so we just did regular anticoagulation.
Quick question for the panel. If you were going to go on ECMO in a 10-year-old, you know, for trauma, would everybody go through the neck for VA?
Yes, I would.
Yeah,
I would.
yeah, but it depends upon where the other associated injuries are and the easiest to access. But I would do in this particular case that Katie presented.
Yeah, I do. I think I do think that there is some facility to going in the neck. We worry a lot about whether or not they have a complete circle of Willis and whether or not they'll stroke. But it's hard to beat the neck for speed, right? I mean,
Yeah.
So.
And so if you look at the timeline, we were on ECMO in 5 minutes. So there's CPR ongoing, got on ECMO in the neck. But it's a really good point. So there are multiple studies. The first ECMO in trauma was actually in Santa Barbara in 1972. So it's been a thing for a long time. And the survival is actually pretty high. If you look at matched controls, we looked at our data. So we had 6 kids and our survival over the last 7 years, and our survival is high, but 2 of these kids did stroke. So, you know, so our institutional bias would actually be to go in the groin. I think I personally in the situation also would have gone in the neck. But it is, you know, another kind of point of debate that we could talk about in a whole lecture of its own.
Yeah.
Did you guys reconstruct the carotid artery or ligate?
So we ligated it. What do you do, Howard? Do you guys reconstruct it?
No, not typically. Mm-mm. Occasionally, in the oldest, like in a teenager, we might do that. But in this case right here, we'd have ligated to get on.
So one other thought, and this also depends on the person power and who you have with you in the room. The last the ECMO that I did 2 weeks ago was an overdose, and a flecainide overdose, and I had my senior fellow with me, and so we needed she was getting chest compressions, and so he was really good. So Tony Ferrantello took the leg. I gave him his choice. He took the leg and I took the neck. And so I put a venous in the neck, modified cut down. And then while he cut down on the groin, and then after I got my venous cannula in, it was perfect for us to do the arterial. And so we got both cannulas in simultaneously. So now I don't know that I can beat 10 minutes. But then 14 is tougher than 10 actually, I think. But that's just something else to think about, is that if you divide, if you separate your venous and arterial, then you can have two people working at the same time.
I totally agree with that. You know, I used to think it was pretty easy to go percutaneous too if you had two people, but you know, you got to be careful that you don't accidentally cannulate, you know, a vessel that you're not trying to cannulate when you're going percutaneous during CPR.
Yeah, my percutaneous now is an incision and then self-insert.
No, I agree. I love that move.
No, that's
Yeah.
what I do. Yeah, that's what I do too. Yeah. So.
All right, well, that was an awesome case.
So this isn't nearly as dramatic as a case as we just heard, but I thought it brought up a lot of pitfalls that kind of we can fall into in pediatric trauma. So without further ado, so this is another kid who was an unrestrained 10-year-old boy at a high-speed MVA. His sister died. Both of his parents were injured and were level 1 activations. So to make a long story short, in the field, they called a helicopter. Life flight came in. They intubated him. They said that he looked to be around 10 years old. He got a 7.0 ET tube. He was put on 100% oxygen. And kind of from go, this kid was very labile. So they had to sort of increase the airway pressure up to around 25 to 30. He was hypoxic, hypotensive, and tachycardic. He got multiple blood products in the field through an IO, and sort of would get better and then would get worse. They put needles in both chests, and they struggled for a long time. He came from a very remote area and didn't really get to us until about 2 hours after his injury. When he came in to us, he was tacky. He's, you know, GCS of 3, his left pupil's non-reactive, and his blood pressures were soft. Couldn't hear any breath sounds on the right and had no lung slide on the ultrasound on the right. And the ED wanted to place a chest tube right away. I was standing in the back of the room and I asked them to stop and made them wait for an X-ray. And that was what we saw. So, yeah. So after multiple sort of rounds of this, they kind of were hell-bent on putting a chest tube in on the left. And so I finally said, okay, we pulled back the tube multiple times. And
wait, can I stop you for 1 second?
Yeah.
So intubated in the field, right?
Correct.
Okay. What would have happened if this child had not been intubated in the field?
So their report was
prior to arrival. I mean, yeah.
Yeah. So, oh, you mean what would have happened if they just couldn't get the tube in?
No. What if they had chosen not to intubate the patient? Would the patient still made it to your house?
Probably. I suspect, and I don't want this to deteriorate into kind of criticizing pre-hospital providers, because these are terrible situations. They don't, at least where I am, intubate a lot of kids. But I think things got worse after the tube went down. And the point I was trying to get at was he was eyeballed as a 10-year-old. And so he got a big tube that was put in really far. And spoiler alert, he wasn't 10. Anyway.
So wait, so Mary, before I let you go, so one of the reasons that I call you out on that is that this guy Howard Pryor, who's on the panel, is writing the new version of ATLS, and he has to decide whether or not pediatric patients should be intubated in the field. That's Howard's call, right?
Well,
Howard,
it's a group of people that write that actually, and there'll be committee discussions about that at length, I'm sure. But it does get brought up. How often should kids be intubated in the field? That's a question that is not well answered.
Who on this panel has seen a right mainstem intubation in the field? Okay, all right, just want to make sure. Okay. All right, keep going, Dr. Edwards.
All right. So anyway, we put the chest tube in. It got no air, got no nothing, and he is just persistently hypoxic. His blood pressure is better since pulling back the ET tube. He's got some blood on fast. I think this is his repeat chest X-ray. So right now we're on 100%. His SATs are around like 83. His heart rate's like 120. His systolic blood pressure is around 110. And I will tell you, in my hospital, I don't have ECMO. So that is not on the table. So what would you guys do at this point would be my, I think that is my next question. So what would you do? This kid.
I'll leave the X-ray up if you could.
Yeah.
Katie Russell, you're on the hot seat first. Your patient's not doing well. They're appropriately intubated. They've had one chest tube, not two.
Yeah, I mean, so to me, you know, looking at this chest X-ray, it looks like the ET tube is in a good position. Is that a chest tube on the left there?
It is. I'm sorry. Yes, it is. And it's in the right spot.
It's good. Okay. So good chest tube. I mean, to me, it looks like there's for sure probably some pulmonary contusions that are pretty significant. The mediastinum doesn't look wide to me. I think it looks okay. You know, I think we've given a little bit of blood resuscitation already. And what are our SATs doing?
You know, so the SATs were the problem. The SATs were like at around 82, which he had a bad head injury, obviously. And so that was kind of what was making everyone kind of excited.
All right. The problem is I don't know what I would do at this point either. So I
don't know.
I can tell you what I did. I figured that he had sat for 2 hours with one lung really not ventilated.
Yeah.
And so I just said, guys, chill out, turn up the PEEP, just bring the airway pressure up. So sort of do like lung recruitment maneuvers. And we did that. And it took about 5 minutes, but sure enough, his SATs ultimately came up to like 95 and we were able to start weaning. We were able to start weaning the oxygen. So I mean, I don't know, maybe I just got lucky, but was my thinking there. So
that's a great thought.
But for the audience and stuff, especially for the trainees, so you got patients intubated, your ET tube is good, you got chest X-ray, but doesn't explain it. I think there's, obviously from the basics, you still go through that dope mnemonic, right? So make sure there's no displacement of your tube, make sure there's no obstruction, suction of the tube, pneumothorax. Obviously, we don't see PEs in kids, but that's always in the back of my mind. And then more importantly, I've been burned a couple of times with equipment. So that whole mnemonic, you go through, but if all of that's negative, you just wait it out and see if you can recruit it. And I think the waiting is the hard part, because I've been there, Mary, before, 10 minutes and my SATs are still 80. I'm like, what am I missing? What am I missing? And doing fast and looking at the heart and looking at making sure I don't have any other sources of why this patient can't get ventilated or oxygenated. But I mean, sometimes it just takes a while, and that's the hard part, is waiting.
And
I will say
we did all that, to be clear. So and the fast didn't show anything in the heart. And so you're right. You're absolutely right, Romeo. It was kind of like, I was pretty reassured nothing else was going on. And so decided it was reasonable to just try and recruit him a little bit.
I think this is a good case to remind everyone that pulmonary contusions can be far worse than they appear on initial chest X-ray. They take time to blossom. A modality that can help you suss that out a little bit more thoroughly is a lung ultrasound. that will show you consolidation much more quickly than a chest x-ray will. But I think these are the terrible cases where you are biting your nails in the trauma bay, waiting for the sats to go up and not recognizing you don't really have that much else to do. And the sooner you can understand that it's a pulmonary contusion that's your problem, the faster you can get on to like ventilator management strategies that are appropriate to protect the lungs as they try to recover, or make a decision for VV ECMO if it's going to be that bad.
So Howard, can you tell the difference between collapsed lung and contusion on ultrasound? Or are they gonna look the same?
It depends on, you can tell if the lung collapse is due to pneumothorax is very easy to tell, but if it's
Sure.
just consolidated lung from pneumonia versus contusion, that's very difficult to determine. No, that's correct. You can't do
Okay.
that.
Mary, I have to hand it to you. I think that you diagnosed it and treated it absolutely on the money, which is, how often do you see a 2-hour mainstem intubation, which is not that long, but I think about the kids that we do surgery on, and and the anesthesiologist gives them a peak pressure of 30, and you're watching the lung and it doesn't come up, and and until they actually sit on the bag and the lung doesn't reinflate because it's been deflated for 2 hours. So yeah, I think you're absolutely on the money.
Yeah, it's a good case.
Yeah.
All right, so onward. Tube of truth. So he has essentially a small epidural, kind of, you can see it around the left temporal bone. He has a pretty bad temporal bone fracture, and we were concerned that it was entering into the petrous portion near the carotid canal. Radiology was very, wait for it, about this. They're like eating a waffle, sitting on a hedge, saying, I don't really know. He also had what was a rapidly accumulating pleural effusion on the right side. He had bilateral bad contusions, probably maybe some aspiration, just based on what the EMS told us. He had a bad splenic laceration. So like good trauma surgeons, we got a CTA. We were worried about the carotid artery. I'm going to try to show this to you. This was read as, again, possible mild narrowing of the left internal carotid artery as it goes through the petrous canal. So if you can see that this is the right side here, and hopefully you're seeing my little pointer.
Mm-hmm. Yeah,
the left side, maybe a little bit, maybe, radiology non-committal. This is another projection. So again, this is that left carotid, maybe kind of narrow coming through here. They said maybe a mild injury. And again, this is the right one. And you got it again, the kid's a little tilty, but that's right, that's left. Everything else was fine aside from the epidural. He had some mild pneumocephalus. Really nothing else significant on his head. So this was the laundry list when we left CT, so obvious head injury, the skull fracture, he's got an orbital fracture on the left. He had this maybe BCVI, he had a big splenic lac. He had an adrenal hemorrhage on the right, which I just rolled my eyes because even though I didn't believe it, I knew that meant he was going to get steroids, but I just allow it now. I can't fight with the PICU over it anymore. He had a right hemothorax, he had a left clavicle fracture. You know about the pulmonary contusions, a ton of left rib fractures. So we get to the ICU and we find out he is not 10 years old, he is 5 years old. He is just a very obese 5-year-old. I put a right chest tube in and got 450 milliliters of blood out like immediately. And realized this kid's 5, his ideal body weight is probably around 30 kilos. And right at the same time, the radiologist calls and says he can't rule out a blunt injury to the hilum or an inferior pulmonary vein. It like right at the same time. And then his blood pressure falls and pressors get started. The ICU is kind of running around because obviously they took the call from the radiologist and then relayed it to me. So anyway.
So at some point we have to get some input. Oh, there you go. Thank you.
So what would you guys do? I mean, would you wait? Would you do a thoracotomy? He has gotten no more blood other than what EMS gave him in the field. And so what would you?
Howard?
Uh,
Got chest
I would-
tube, got some bleeding, got 450 mils out in a 5-year-old.
I would not wait. I would proceed to the OR. I would plan for resuscitation. I would call for blood, and I'd plan to go get control of this. I would be expecting to do this through an ipsilateral thoracotomy, but I would also probably, if I had an option, contact my CV colleagues just in case we're gonna have to get more exotic.
Katie, put him on ECMO.
No, not yet. Not
Okay.
yet. Is it still pouring out blood out of the chest tube, or it was just 450 and stopped? or-
I am not going to make it easy on you.
I'm there. I want to look. I got to look before I make a decision.
So okay, I'll tell you this, over about 20 minutes, like 450 was in the pleurovac. So, yeah, I mainly had to make a decision because the PICU, I was kind of losing their mind. And he was not that unstable. I mean, I think they were getting excited and getting pressors because mostly the call from the radiologist coupled with what happened. But I was a little worried, that he had no effusion when he came in, and now he's got 450 mils in his chest,
Romeo, do you want to operate on a?
MTP. I'm activating MTP, and I'm going to sit at the bedside. I'm not going to go right now, but I'm thinking, okay, guys, I might be coming, but give me another 15 minutes to check this out.
No,
Romeo, do you want to operate on a pulmonary vascular injury?
no, I don't want to operate on a pulmonary vascular injury. However, I would be like Howard, worst case scenario. I would do a sort of a combination of what Katie talked about: MTP, resuscitate, go to the OR, prepare for the worst, and if you have to, yes. But I'm going to call my cardiothoracic surgeons for assistance on this one. So
Okay.
And I would not, my personal preference would be to, during the resuscitation, to sit by the bedside, but not do it in the ICU, but rather in the OR.
yeah, absolutely.
Okay, I'm with Howard on that, 100%.
Let me tell you, I do the math on this, and this is not 400 mils in 20 minutes. This is 400 mils in 2 hours and 20 minutes. And pulmonary vascular injuries stop bleeding. So that's my bias. So
So you would just keep them in the unit and just watch them and see how
if this kid came to me 20 minutes after the injury and I got 420 mils out, I'm going to the OR.
Okay.
If he comes to me 2 hours and 20 minutes later, I'm not sure. I'm not so sure about that.
That's fair.
So I waited. I waited. I thought the same thing as David, and it did stop. And I kind of thought maybe it was due to the needle thoracostomy. I figured they might have hit a intercostal vessel or something like that. We did get a CT of his chest, and I know that's not perfect, but I went back and looked at it, so it was fairly reassuring to me.
Like a CTA of the chest.
Yeah, it actually was. It actually.
Oh.
I'm a little bit more worried about that splenic injury.
Well, yeah, that was anyway. Okay, so anyway, I'm going to fast forward a little bit. So we're at ICU day 1 to 2. He had a monitor placed. His pressures are his ICP pressures were normal. His left pupil was non-reactive. Ophthalmology came and dilated him and said that was just because of an optic neuropathy, probably from trauma. Ventilator got weaned. We were kind of up and down on that. We were not fast enough to exchange the ET tube. So this is a 5-year-old with a 7.0 ET tube. And, I will tell you, this is not on EMS. This is on me because, and I think it was just one of these mental traps you fall into. You looked at this kid and you were just like, this kid is not 5. This kid is 10. But he was 5 and he also was on fairly high pressure. So of course he had a leak, but you know, after about 3 days, I finally thought, oh yeah, we do have to change this. And so we did change it. Of course he got steroids because radiologists say it was renal hemorrhage. Then we put a PICC line, the pressors came off. You know, the whole hospital was consulted on this kid and no one wanted any interventions, which is not surprising. Anyway, so my question for the panel now is back to that radiologist eating a waffle sitting on a hedge saying
BCVI.
there might be a small narrowing of the ICA. Would you treat it? I mean, what would you do with this?
I'm going to turn this into a vote. So Romeo, treat, don't treat.
Like just a small dose for aspirin. But yeah, I would treat.
Okay, Katie Russell, treat, don't treat. Possible grade 1.
We're 48 hours out. I don't think the pulmonary vein's bleeding anymore. The spleen stopped bleeding. Yeah, I treat it. If I at all was still worried about those things, I would say, no, guys, we're not going to treat it yet.
Howard Pryor.
Treat it.
Okay. You know, aspirin's free. I mean, you know.
Yeah.
Yeah.
Well, you guys were smarter than we were. So we caught our endovascular neurosurgeon. We do have one of those, who was, quote, not impressed. And they were all worried about the high risk of bleeding. He had an ICP monitor in. That was another thing. You know, we put him on Keppra. They said, you know, we did our supportive care algorithm for severe TBI, and they just said, we will plan to do a repeat CTA in 4 days. He was very stable. And yeah, we went through all this. So goes back for another CTA or CT. And sure enough, he's got evolving infarcts kind of in the parietal gyrus, in the left basal ganglia. And I'm not even going to try to interpret this for you, but now the radiologist is saying that this is a grade 2 to 3. You know, interestingly enough, the same day this happened, he developed a DVT around his PICC line. And so I kind of wonder if something was going on. He got hypercoagulable all of a sudden. It was just sort of this phase in his traumatic coagulopathy. We hadn't really given him much in the way of products after that first day. He got 1 unit of blood and that was it. We didn't do a tag on him. You know, his INR was like 1.3. But anyway, after this, we took the bolt out and started him on low molecular weight heparin. And then
Wow,
so
that's a gutsy move in itself.
I know.
Yeah.
Yes, it was. We waited a day and started it the next day, and he didn't hemorrhage into those infarcts.
Yeah.
But yeah.
So I would have to agree with your concern about hypercoagulability. Every time that you go to an adult trauma meeting now, like AAST, there's definitely hypercoagulability associated with traumatic injury, and and it's a question of when you measure it, right?
Yeah.
So Barb Gaines published that every patient that comes in is hypercoagulable. I think that may be an overstatement, but do you guys remember that paper?
No, I
No.
do, because the problem is that because we don't see it very often in peds, our guard is not up, but every trauma patient still has that hypercoagulable, even if, we always talk about the differences in ages and stuff, but this is a patient that, hindsight's, obviously great, but, aspirins for me is fairly innocuous in this particular state and stuff. So yeah, it's a tough case.
Charlie Cox has a paper that points that out, that with severe head trauma with a skull fracture, that the hypercoagulability sets in at like 36 to 48 hours. And I think that's that's just consistent with the adult literature too, which says that at around 48 hours of the head injury, that's when your hypercoagulability will set in after all the resuscitations settle down. So I have a lot of institutional resistance, though, I'll tell you, from the neurosurgery service to give aspirin in that scenario. Has anybody used Cangrelor?
No, is that like a bulletproof vest?
No, it's a YP2 or what is it? Y12P something inhibitor that's fast on, fast off. It can, it'll inhibit platelets for about an hour after you turn it off, and then they'll go back to normal function. So for arterial clotting, it's like the ideal medication to give when you can't afford to have it get out of control.
Never heard of it.
No, that's a first for me.
I've used it a couple of times on ECMO patients that have 8 French cannulas, and it prevents the accumulation of clot at the end of those little cannulas.
Wow.
That's
good.
All right, Mary.
I'm going to pick it up because we we need to move on with this. But I did want to ask one. I seriously want to know what you guys think about this next thing. So now we're at ICU days 5 to 14, and the pulmonary contusions are just hitting us with full force. And he's gone up and down in his vent requirements. They try and extubate him on day 14. He fails. You know, he's ventilated. He's agitated. He's got a head injury. So I go to the PICU with this extremely radical proposition.
Great.
When would you guys consider tracheing a 5-year-old kid with respiratory failure and a TBI? Like, when would you pull the trigger on that?
Day 7.
Day 7?
That's when I would begin the
14, aren't we?
discussion.
We're day 14. We are
Yeah.
day 14 now. Yes.
Yeah.
Jensen wrote this paper.
And this is a time frame that you would definitely consider or even do it at this point here, because the long-term outcomes for those, you know, typically, and unlike adult hospitals, we are somewhat reluctant to do trach and G tubes earlier, like in the adults. But Aaron's paper clearly shows that there's a benefit for earlier trach and G tube. You know, we sometimes let these kids sit for 3-4 weeks, and the reality though is
Even in kids this young?
yeah.
Yep.
Yeah.
All right.
Yeah, and so you know, when Aaron presented that paper that the kids that got tracheostomies did better, my thought was I need to see another paper before I change my practice. So at my institution, this kid would not get trached, not for a long time.
I think I think that's a good way for us to, you know, really seriously think about that, because, you know, the culture for us is not to do that, but that doesn't mean it's necessarily the best option for us. And so we do have to get more data for pediatrics to figure out if this is the right thing to do for it. But I already, you know, it gets to 7-10 days, I start having that discussion with our PICU, but there's been a lot of resistance, even at my institution, to do early trach and G tubes. And we just don't see that many here in San Diego.
You know, and with neurocritical care rotations, you see that these TBI kids, particularly when it's a frontal injury, where they're going to have a lot of, I mean, and a 5-year-old also will have no real actual self-control anyway. They have to give so many drugs to keep these kids tolerating an endotracheal intubation that actually put a trach in, and all of a sudden the drugs vanish. And the drugs that they're being given cannot be good for neuro recovery. They just can't be, because it's like body weights and horse doses of sedatives to get them to stay still. So that's the scenario where that's another reason why I believe I've seen so many head injuries just do so much better almost immediately as soon as you put a trach in, because they stop flailing, because they're not reacting anymore to the endotracheal intubation.
So Mary, the suspense is killing me here.
So it's like, so Howard's like a sage. So, you know, I could not convince them. I couldn't do it. Anyway, he had to fail extubation 2 more times before finally I was able to get them to do it. Once we trached him, he was off the vent 2 days later. It was like magic. But I will, you know, just to come back to this. So
Wow.
that
Wow.
7-0 tube and those multiple reintubations, if no one here has ever seen like a subglottic injury, this is exactly what it looks like. So, you know, here are the cords, they look like dog meat. And then under in the subglottic area, you can see just all this kind of pressure necrosis. That's the trach there. So anyway, he did get ultimately transferred to the floor. He had to go back to the OR a couple times, but ENT was able to dilate this and inject it and dilate and inject it. Ultimately, a few months later, we were able to decannulate him. He progressed with his oral feeding very quickly, got this G tube out, you know, but this was the stenosis, and this was after one injection and one balloon dilation, but ultimately he did get decannulated. He went to rehab day 40. He ultimately was taken off the low molecular weight heparin 6 months later, and currently he's back in school. He does have some residual, you know, deficits, particularly with speech. He was a little bit delayed to begin with, but he is recovering well. So I don't know, you know, the lessons learned I did with, to me, obese kids look older than they are. And really, you have to use the Broslow tape, all these formulas that are age-based when it comes to like the endotracheal tube and how deep you put it in. This is a classic example of falling into that trap. And so you got to use the Broslow tape. If they used the Broslow tape, you would have got a 5.5 tube and it would have gone in at an appropriate depth, even as obese as he is. Broslow tape's not perfect, but it's better than guesstimating the age. And then blunt CVI in kids, it's just so challenging. I really struggle with it. And then after this case, we changed our practice and we do exactly what you guys suggest. You know, if it's day 7 to 10 and they're not off the vent, we're really talking about tracheing them early. That's all.